well? The little squares?
No.
No, okay, you know what I'm talking about?
No.
The hand-drawn one has like 4 boxes.
And it says make your notes to remind yourself how
Yeah.
you use your transducer.
Yeah.
I thought that's what the worksheet was. What's
No,
completed
the
triple?
worksheet, I don't have it here. The worksheet's what we complete for the exam. We went through a writer-book quadrant 1 where we said history, indications, and all the information that we got during the exam, and then the comments go at the bottom, what we found on the exam.
Oh, we have to complete that?
Yes, you do.
I mean, on our own? Like you just make something up and write it in?
And we'll talk about it on Monday as a class. That way everybody's on point with it.
Oh.
So right now, the big things I want you to work about are protocol images taken in lab, and then your protocol notes sheet. And we'll do the worksheet, RAD report, and talk about what pathologies to include on Monday.
Okay.
So, but you know, we talked about that, I remember this.
It was mentioned once and then forgotten.
Understandable. Okay, so on to the liver.
class.
So we talked about kind of the 4 parts of the liver. What are the 4? We ignore one of them. This is weird to be. I don't know where to stand. Okay, so we talked about 4 parts of the liver. What do we got? What are our big sections? There's 2 of them already up here.
Right liver lobe, left liver lobe.
And then which ones? There's the caudate lobe that lives
Posterior.
cut up and anterior to the IVC, kind of that little chunk. And then who's the ignored guy?
Quadrate.
Quadrate lobe. You got it. So we use the IVC to divide the right liver lobe and the left liver lobe. So when we're in sagittal and we're seeing that IVC, everything from IVC to the left is going to be left liver lobe. Everything just past the IVC is going to be right liver lobe. Sag left liver lobe. So we're going to take 3 images. So we're going to have, let me backtrack a little bit. Transverse has a lot more landmarks when we're scanning. So we have the dome. There's no vessels or vasculature there. Then we get into like hepatic vein land. Then we get into portal vein land. And then we get into right kidney land, or on the left liver lobe, it's going to be pancreas land. Those, the pancreas may not be in your images, it's just the idea that it's the most inferior. When we're moving through in sagittally, it's harder to know because landmarks, there's just nothing really there. We have the IVC, and that's kind of it. So for sagittal, we're going to sweep through that liver, sweeping for pathology, and then we're going to take a medial image with the IVC, a mid image, and a lateral image. And I'll draw this on the board, we're ready to roll here. So, actually, we're ready to roll. Let's go right now. You guys can't see his. How about over here? So here's our liver. So we've got IVC running through here, some little hepatics coming up. That is a terrible hepatic. He's kind of back here a little bit. And further down, and then we have our aorta on this side. Okay, so this IVC, not drawn to scale, this is going to be our border for the left liver lobe. So everything from IVC over is going to be left liver lobe. So we're going to sweep through here to kind of get an idea for how much distance we need. And we're going to take one image in the medial. So we're going to have a medial with IVC. Somewhere in maybe aorta land, maybe not aorta land. We're going to take a second one. That's going to be our mid. And then we're going to take one out in this lateral aspect. Now these are all just going to be annotated, sag, left liver lobe. We don't have to annotate specifically which area we're in. So so that left liver lobe, we're going to find that IVC. We're going to take an image with the IVC for the medial left liver lobe. And we're going to move slightly over to the mid, and then over a little bit more to that lateral. So we're going to have 3 images across the left liver lobe. So in IVC border for our medial, no landmark. You may see the aorta for that mid image, and then again, no landmark. You're just going to reach the end of the liver and come back a little bit. So those are sagittal images for the left. Now, transverse is a little bit easier because we have some landmarks. Next slide. Let me get a workout here. Okay, so we're going to take 3 images from superior to inferior. Let's get our liver out of here. And the liver is kind of an odd organ just because of its weird shape. So we're gonna liver it up again. So we've got the IVC right in here. He's got some hepatics coming off of him. And so for transverse, we're gonna take one at the dome. I'm writing on this people's stuff. Don't do me, no. So it's gonna be our superior image. And these are all, again, annotated transverse left liver lobe. We're gonna have one in the mid, what we call kind of vessel land. So you may have some hepatics in there, you may have some portals in there, you just wanna kind of show off some features of that liver. And then we haven't really played with the pancreas yet, but he's gonna live down here. And so our inferior one may or may not have panc in it. We kind of call that panc land. So we're gonna have a superior at the dome, a mid at vessel land, and an inferior at panc land. So to backtrack, sagittal, IVC, medial, mid, lateral. This is gonna be dome, superior, vessel land, mid, panc land, inferior. Feeling cool so far? And there's actually a poster of this that the students made last year down in the lab that you can peek at. Okay, next up. Right liver lobe's a little bit harder. He doesn't, especially in sagittal, he doesn't fit on our screen the whole way. And so what we end up doing is kind of splitting up the superior portion of the right liver lobe and the inferior portion. So we're going to use that subcostal or subxiphoid window, and we're going to sweep over and get images of that superior portion. So we're going to have 4 in this case, because that side of the liver is so much larger. So here's our liver. Got, let's say, IVC right in here. So we won't be able to take our probe and image from top to bottom. Borders, 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 right? We want our borders. So in this case, we're going to kind of divide this liver in half a little bit. Boop. So we're going to get our first image is going to be just off that IVC. IVC. And this is going to be our medial. And this whole thing is, again, just annotated sag right liver lobe. Then we're going to go to our mid-medial. Then we have a mid-lateral and our absolute lateral. So we have 4 images across the top. Scanning that subxiphoid area. So we're just going to kind of push under, and right now you guys are kind of used to being stick straight on that aorta, but we're actually going to kind of sweep under that rib cage, kind of shine our beam through, kind of through the soft tissue inferior, well, posterior to the rib cage. So here I'll repeat it. So we're going to come right off that IVC. We're going to have 4 images. We're going to have a medial, mid-medial. Oh, hi. Good morning. Mid-medial, mid-lateral, and lateral. So 4 images across the top. Well, Shea, we've missed the entire bottom of the liver. Oh, I know we did, because it doesn't fit in our field of view. So then we're going to slide down our kind of subcostal to intercostal margins, and we're going to get 3 on the bottom down here. We're just going to have a medial, a mid, and a lateral. So 4 across the top because he's so much bigger, using that subxiphoid neighborhood, sliding down our costal margin and getting those bottom 3, a medial, a mid, and a lateral. Where we end with this lateral just happens to be right kidney land and what we call the midclavicular. And what do we do with the midclavicular? What's that our landmark for? Measuring the liver. Oh, that's right. Remember, we measure the liver in the midclavicular plane, that right liver lobe. Are we still following? Still tracking? Okay. Now, transverse, similarly to the left liver lobe, is going to be much easier to evaluate because it has all those landmarks. So not a lot of landmarks in SAG, tons of landmarks in transverse. So we're going to take 4 images in transverse, and again, they're all annotated transverse right liver lobe. We've got a little kidney down here. So we're going to take one at the level of the dome. Maybe let me draw few more landmarks for you here. So IUC. And we've got that porta hepatis with our portal vein, our main portal vein coming through. And we've got our kidney. So we're gonna take one, okay, let me revise this just a second. So hepatic veins, so IVC, hepatic veins, MPV, RK. Not R. Kelly, he's kind of weird. Okay, so with this, we're gonna take 4 images. So we're gonna have one at the level of the dome, one at the level of the hepatics, one at the level of the MPV, and one at kidney land. So much easier in transverse, we have those landmarks. How you guys feeling about this so far? Confused and disoriented? Yes, great, okay. So let's review. So we're gonna start in sagittal on our left liver lobe. God, it's like staring into the sun. So what's our first 3 images for sagittal left liver lobe?
Medial.
Medial. And what's our only landmark we really have for medial?
IBC.
IBC. Okay, who's next? Mid, and then lateral. You got it. So 3 across the left. So medial with IBC, mid just kind of in the middle of things, and then lateral aspect. Now we're going to do transverse sagittal, or transverse left liver lobe. What do we got?
Superior.
Which is, our landmark for that is?
The bare area or
The dome.
the dome.
The dome. Then next up, vessel land, which is kind of our mid, and then we get to the more inferior aspect. Pancreas. And the idea isn't that you have to have the pancreas in there, it's just part of the neighborhood. So if you know you're at the pancreas, you know you're at the inferior portion. So we're gonna go into our sagittal, right liver lobe. So what are we doing across the superior aspect of our right liver lobe?
Medial.
Medial.
Mid-medial. Mid-lateral. Lateral.
Awesome. And we're gonna slide down a little bit down here, and then what do we have down here?
Medial. Mid. Lateral.
You got it. And how about our transverse? Who's at the very top? Dome.
MPV.
Kidney land. Is that making sense? We're gonna cutting this thing up in pieces. The tricky part is it's not a symmetrical organ. So you have like different number of images for one and not a lot of landmarks in sagittal. So you just have to be like, this is where I'm at. So I sweep that left liver lobe and I know how big it is. So I know I need one image here, and one in the middle of the 2. But if I have this little tiny sneaky left liver lobe, then I'm not gonna have much distance between those images. And that's okay, it's just gonna depend on the patient. We don't have to be in the absolute perfect middle or the absolute lateral, because once you get to the lateral, it kind of disappears. I want to see some meat and potatoes. And when we scan here in a few minutes, you'll kind of see what I'm talking about. Any questions so far?
So when you sweep for the borders, are you having to prove that with a live kind of feed of some kind where it's showing a video of you sweeping through, or?
So they call those cine clips, and we use them from time to time, but we're going to talk a little bit about, we just want to include that border in our still images.
Oh, okay.
Yeah. So optimizing the liver, we want that kind of even gray. Questions so far? Good to go? So for optimizing, we want that even gray from top to bottom. So we might have to use those TGCs. That liver attenuates a lot, especially in bigger patients. So what's attenuation?
Loss of amplitude.
Loss of amplitude, right? Our volume gets less as it spends more time in the patient, plus the liver attenuates a bit. So we might have to use those TGCs to get some even gray from top to bottom.
What's the TGC button again?
The sliders, all little things on the slide, yeah. We want to show the features of the borders of the organ. So if I'm like in no man's land and I can move just a little bit to the side and show a portal vein, show me portal vein versus just having no man's land. And this is true for everything. Just shows some features of the organ. We want depth correct. That left liver lobe has much less depth. And even as we go through our transverse images or sagittal images, we may have to adjust our depth as we go. So what's the big key about showing that diaphragm?
Pleural.
Yep, you're proving or disproving pleural effusion. So we want enough depth that we can see posterior that diaphragm, but we don't want to be scanning all the way through the bed. So we want, you know, a couple clicks of depth after. Our focus, we want in the far field. Remember that hourglass? They're shaped like hourglasses. And our best resolution is where our foci is. It's the narrowest portion of the hourglass. So we want to make sure our hourglass, where the focus is, the waist of the hourglass is below the organ, at or below. And we'll learn about that a bunch in physics. And then 2D gain if needed, just Mike loves frequency button, I don't do much with it, but 2D gain if needed, use our TGCs, and then if we have to cut off borders, and I'll show you this on the left liver lobe, take 2 images, just take an additional image. No one's gonna spank you, take away your birthday, because you did it, yeah.
I have a question about pleural effusion. So, you go over and like show like 1 or 2 photos. Honestly,
We're gonna go over it a little bit today.
Okay.
Yeah, yep, you got
I
it.
was like confused about that.
Okay, so in this case, I can't even see what it said. So we're in the transverse right, and when you initially put your probe down, you may have this border cut off. So we're gonna take our probe and point it towards our patient's right shoulder, and that will get that lateral border in. That's really important. Lots of hairy scaries like to hang out there. We don't want this border to be cut off. And then the far field, a little bit bright. If you look, we're in bright class, so normally we work in the dark, so it might be hard to kind of peek at this. But we want a little bit more even gray, and we're a little bit bright down here. Our depth is looking good. So pleural effusion is fluid that collects outside of the diaphragm. So we're gonna see at the bottom of our patient, whereas ascites, which we talked about with pathology, is gonna be more surrounding the liver. Or you might see it anterior to the diaphragm, or in that Morrison's pouch. What's Morrison's pouch?
Space between the liver and the kidney.
Yep, right, got it. Okay, oh man, what a terrible sonographer. So you can see that our border's cut off here. So how would we fix this? We're in transverse. How would we get that lateral border? Yep, towards the patient's shoulder. You got it, absolutely. And then maybe a little excessive depth. Like I could, you know, maybe get rid of a little bit of depth here and call it a day. Okay, so this one, oh man, this sonographer really needs to go back to school. So in this case, we're showing IVC, hepatics, and transverse, a little bit of portal, and we are not clearing this border out at all. So if this went to a court of law, this patient had carcinoma over here, and they're like, how come we didn't see it? I don't know. Well, none of your images have the borders, so we want to make sure that we're including those borders. And maybe a hair more depth, I don't know. Okay, so this is going to be where we take our midclavicular measurement. So we're in sagittal, Morrison's pouch, and when we do this, sometimes this happens. Out in the real world, we can do what's called wide scan, and I can actually open my beam to include that inferior. With us, we've got kind of janky machines, and so we're going to measure from the superior posterior to the anterior inferior. And we're going to have to know with our machines now, like, how far does this extend? So you might have to rock your transducer just to see, does it go all the way out here, or does it end somewhere in here? So it's kind of one of those things we have to kind of, what's the word for? Yeah, that's a better word than I was thinking of, but yeah.
How would you do that? Like, would you like still use the calipers and stuff, but on the image wouldn't it's already show how much depth it is? And
it's not a depth at the length measurement of the liver, yeah. Because we get depth like measurement here, but we don't have any, you know, we don't have any information going this direction. And this correlates to CT.
Can I go back to image 12, where you were saying that the border was cut off to
yeah, right in here.
And so you would improve this by just zooming out?
No, you're going to angle towards your patient's shoulder.
And then you would still get the IVC and
so
portal
everything
veins?
from here over is left liver lobe. So we're showing right liver lobe and left liver lobe, but we've already taken images of the left liver lobe.
Okay.
So we don't need to worry about this guy hanging out.
Okay.
So we're just going to kind of more center our image on the right liver lobe showing that border.
Okay.
Okay. Okay, so in this case we're looking at left liver lobe, and we're probably in the mid somewhere. We're not seeing IVC, maybe smidge, but in this case we've got the superior border is cut off and the inferior border is cut off. So to combat this, we would just take one image here, slide our transducer down, and take a second image here, just to include that additional border. Like, oh, it's too big to fit, let's take 2 images, not against the rules. No one will fire you, I don't think. Okay, so overall this is a little bit bright. We have kind of a nice inferior border of the right liver lobe. So we're going to measure that superior posterior all the way to that anterior inferior. That's going to be the measurement. That's at that midclavicular line. Additionally, we want to show this image to disprove or prove which pathology, 2 I can think of. Ascites, in that Morrison's pouch.
Hepatomegaly?
Not necessarily, well, that's a measurement, but just this image in itself. When do we compare the echogenicity of the kidney to the liver?
Fatty liver.
Fatty liver, you got it. So that's why this is one of the important images of our protocol as well. So we'll use it as a measurement image, and we'll also use it to compare that echogenicity between the 2. Okay, so this, pleural effusion. So we're in transverse. This is possibly, I'm going to say possibly IVC or maybe main portal vein without very much brightness. We're a little dark in here, we might want to TGC this up. So here's our diaphragm, and see we have fluid collected below the diaphragm. So this is actually lung right in here, and you'll see it move, so our patients breathe, it's totally crazy. But this would be a pleural effusion.
Could that also be, like you said, ascites or something?
So ascites is going to be, so here's our diaphragm. Ascites is going to be anterior to that, around the side of the liver. The diaphragm is like so if you think about it, it's like an umbrella. So if I have fluid up top, in this case our patients are lying on their back, so it's going to accumulate kind of the posterior aspect. Or if I have fluid down below, it's going to be below that diaphragm, which when they're laying on their back, it's going to look anterior to the diaphragm. Okay, so here's ascites. So here's our diaphragm in this case, and we've got fluid surrounding that liver. And I don't know if I named it, I don't know what that means, I don't know. You got it. This is severe ascites. So in this case, here's our diaphragm, and fluid enhances, so that's why this looks very, very bright. But here's our liver, and it's surrounded by fluid. Let me look on your screen. I don't know. It just looks hypoechoic.
It looks sad.
It does look, whatever it is. There's some mesenteric mass or something. Okay, so not the best image, but here we have our diaphragms here. We've got our liver here. Here's that right kidney, so here's that Morrison's pouch. We've got fluid in that Morrison's pouch. And there's potential spaces that we have to talk about. These doors fans. So there's a pouch of Douglas in the pelvis, and then there's Morrison's pouch, and his name is James Douglas Morrison. So if you're a doors fan, it's an easy way to remember your potential spaces.
Okay, so the bottom is the kidney, right?
Yep. Yeah. Right in here. Does my mouse show up? Absolutely not. Okay. Okay, so what do we deal with? Ascites or pleural effusion? How do we know?
It's about the diaphragm is here and it's up there.
Yep, you got it. Ascites or pleural effusion?
Pleural effusion.
Pleural effusion. So just help you, just helping you figure out. Okay, ascites or pleural effusion. We have 2 arrows going on. Both. Look at you guys. Look at you, smarty pants. And what's going on with our gallbladder wall? It's thickened. Why is it thickened? It's a soggy crouton, right? When you have ascites, it kind of like a little sponge, and it soaks up the additional fluid just from being surrounded, being bathed in ascites fluid, so it gets a little bit thick. It's the soggy crouton. Okay, so scan technique for our left liver lobe, we're going to be mostly subxiphoid. Pushing and scooping. So far we've been kind of using our transducers in a real flat way or a real neutral way to get that angle to the aorta. But in this case, we're actually going to go below that sternum and really push and scoop under it. So pushing and scooping. And that's going to be something that we're going to have to do for a lot of organs, and we haven't had to do it yet. So that technique of kind of pushing and scooping. Big breath in and hold it will help kind of bring everything down, kind of move things, the thorax fills, the lungs fill, pushes the diaphragm down, it gives us a little more access into that rib cage. Okay, so again, for the scan technique for the right, for those superior images, we're gonna start kind of by pushing, scooping under that subxiphoid, and then as we get towards the more inferior, we're gonna go move down the ribs and kind of see what we can get. The other thing about this is, there's like a mat of bowel gas that you guys probably encountered when you're doing the aorta. So if for some reason you can't see what's going on with the right liver lobe, the more lateral and posterior you go, or intercostal, the more window you're gonna have. Because the bowel gas lives here, so if you're like, hey, I'm really trying to get here, what's going on? You can always move more laterally and posterior. Transverse. So sometimes we want to kind of get down here and our transverses get a little bit oblique. That's okay. We just don't want to be totally oblique that we're back to sag. So they might be slightly off axis. Big breath in and hold it, and then borders, borders, borders. And the right liver lobe borders are much more difficult to clear out than the left liver lobe borders. Just because it's a larger organ, we're dealing with much more rib cage, there's a lot more bowel gas. Okay, so some things to think about. We talked about AIDIT, which is, what is this? What is AIDIT? Did I put it up there already?
Acknowledge.
Acknowledge, introduce, duration, explanation. Thank you for having testicular torsion. This is amazing. Yeah, and so kind of explaining the exam. So I'm gonna put some gel on your skin and take a look at your insides. That's kind of the dumbed down version, works great, because not patients are gonna be like, I'm gonna put a coupling agent on your abdominal area, and you know, like, what was that? So gel, breathing, so have you take some deep breaths in and hold them. I may have you roll up onto one side or the other to get a better look at things, and it usually takes about 30 minutes for you guys to be roll. But, and then checking in with your patient. How are you doing? Everything okay? You know, just every now and then, every few images, when I have to roll my patients for their gallbladders or when I have to roll them for their livers to what we call LLD, I'll just say, hey, are you okay like this for a few minutes? So just to kind of check in. And then discharging the patient thinking, but when to expect results. So I usually do something like, I'm sorry you don't feel very well, hope you'll get out of the ER pretty soon, or I hope the rest of your day goes a little bit better than this, or my other one's like, I hope to see you at Starbucks, not here again, you know, kind of like, And then when to expect results, and that's mostly for outpatients. And I think I mentioned this before, if I have something really hairy, scary, I'll say, if you haven't heard from your doctor within a week, go ahead and follow up. I'm not saying like, hey, you're gonna go talk to your doctor, but the idea that, you know, make sure you follow up so they don't get kind of slip through the cracks there. Okay, so we don't have that. Okay, that's it.
I have a quick question.
Sure.
About like positioning the patient. When is the best time to position that like left lateral?
So when we do livers, we have to do gallbladders in two planes. So we have to do supine and LLD for them. That's just a requirement that we have two positions. So in your protocol, you'll do aorta, IVC, liver, and then next week we'll get into hepatics and portal veins. So you do your hepatic and portal vein assessment, gallbladder, then I'll roll them to do the gallbladder again. Every now and then, you're gonna see the liver better when you roll your patients, so don't be afraid to retake some of those images. So they might be kind of poopy when they're supine because of bowel gas, but especially bigger patients, like male, like big kind of chested patients, males especially, when they roll, the whole liver will kind of pull out from underneath the rib cage, and you'll be able to access it better. So if you're having a problem, get your other images out of the way, and then just roll your patient and start your right liver lobe, or mostly right liver lobe. It's not really a matter for the left. So, but it's gonna be one of those things like, do I need to move them? So there's one required time to move them.
So for now, not to really.
No, until we get into gallbladder.
Okay.
Unless you're scanning, you bring somebody in and they're tough scan, try scanning, but I encourage you to absolutely try scanning. Like, I don't know how much open lab time you guys have been putting in. Put a transducer on it, see what it's like. See what it's like when they're in PO, see what it's like when they eat, see what it's like when they're laying on their side. Like, just start trying it, because we're gonna have to build all of these skills up. So it's better to kind of flail around and be like, I don't know what I'm doing. And then later you're like, I kind of know, and then you're like, I'm amazing at it. So don't be afraid to challenge yourselves and just experiment with things. You're not gonna hurt anybody. I hope not. Okay, any questions before we disappear back to the lab?
So then, just in summation, we're doing like 3, 6.
So 6 total, so 3 and 3, and then 4 up in the superior, 3 in the inferior, so 7, and then 4 in transverse.
Okay. still, and we're not measuring anything, are we, except for the subclavicle?
We're gonna measure, and I'll talk to you about this, we're gonna measure the left liver lobe at exactly midline, because it correlates to CT. Not a lot of sites do it, but I'd rather give you guys a lot more in your protocols, and then you go to a site and you're like, we don't do that, what are you even doing that for? And you're like, gosh, Shea told me. Versus having to go to a site and be like, I don't know that, I never learned it.
Okay.
So not a lot of sites do that left liver lobe measurement. I do just because you guys are learning my protocol, that's my muscle memory. And then, but always doing that right liver lobe, always, always.
Okay.
Okay,